department or burn trauma center that the patient's injury is confined to a burn wound itself, and that there are no concomitant injuries that may be more life or limb threatening. Secondly, you want to be able to accurately communicate whether or not there is an inhalation injury, which may change the way the emergency department or burn trauma center is going to prepare to receive that patient. And finally, you want to be able to describe the burn injury itself. Specifically, you want to be able to communicate whether we're dealing with a partial thickness or full thickness injury, a combination of both, and what percent of total body surface involvement they can expect when that patient reaches the emergency department.
It is common that a patient will suffer from more than 1 degree of burn. Generally, you will find that a burn victim has combinations of degrees of burns. This makes evaluation more complicated because it's necessary to estimate the respective sizes of the degrees of burns. Your proper evaluation of burns and patient assessment can determine whether the patient should be transported to the emergency department or burn center, and allows early preparation for the patient at the healthcare facility.
Depth of burn is traditionally discussed in the United States as first, second, and third degree. First degree burns imply that the burn is superficial. It involves only the outer layers of the skin cells. The way you recognize a first degree burn is that it's red, it's dry, and it's painful. The common first degree burn that we should all understand very well is the sunburn. First degree burns in general don't require special treatment. They will heal. Simple over-the-counter creams to keep the patient comfortable, aspirin for pain, and the first degree burn gets well. A second degree burn involves deeper cell layers in the epidermis. The hallmark of the second degree burn is the blister. When you see the blister, you can be safe in presuming that this is a second degree burn. A third degree burn, by definition, means that the entire thickness of the skin is destroyed. Third degree burns appear dry, leather-like. They may be brown or black or gray, and they're insensitive to pinprick. The nerve endings in the deep layers of the skin have been destroyed. So the third degree burn is leather-like. So in a quick review, first degree, dry, red, painful. Second degree, blisters. Third degree, leather-like. The other vocabulary that we use in talking about the depth of burns is to say partial thickness and full thickness. Partial thickness includes first and second degree burns. Full thickness is the same meaning as a third degree burn. The other vocabulary that we use in describing burn patients involves the extent of the burn. We do this by describing it as a percentage of the body. So when we talk about a patient with a 50% burn, that means half of their skin surface has been burned. A 10% burn, 100% burn fall into those categories, and we have a mental image. Now, for your purposes in using this language, you have to inspect the burn wound to know the depth, but you can estimate the extent in a number of ways. One is the patient's palm makes up about 1/100th of the body surface area. So the patient's palm is 1% of their body surface. So if you see a burn that corresponds to 8 palms worth, now this is the patient's palm, not your palm, that's an 8% burn. The other helpful rule in determining the size of the burn is called the rule of nines. The rule of nines tells us that the body surface area can be broken into multiples of 9%. The upper extremities are each 9%. The head and neck above the collar line is 9% of the body surface area. The anterior trunk, 18% or 2 nines. The posterior trunk, 2 nines. The lower extremities, 2 nines. It's not important at the scene most of the time to do this kind of calculating. However, in a situation where you have mass casualties to deal with, You must know this vocabulary so that you can communicate with your center where triage is necessary. You can't call in and say we have patients that are bad, pretty bad, not so bad. But when you deal with a physician, or when your local hospital deals with a burn center, and you say I have a 34-year-old patient with second and third degree burns over 35% of their body, we all know what you're talking about, and we can prioritize patients in triage based on those kinds of measurements. So it is important that you know the depth of the burn and the extent of the burn.
Infants and young children do not have the same proportions as adults. Their heads are about 18% of total body size, and their legs are about 14% each, as shown in this diagram. Whatever method is used to estimate burn area, this should not delay transporting the patient. This information is important, but it should be treated as an estimate, not a precise computation. Thermal injuries can also be caused by hot substances coming in contact with and sticking to a patient's skin. This type of burn continues to destroy body tissue after the initial contact. Remove any burned or charred clothing from the affected area. Immediate treatment will alleviate pain and stabilize the injury.
You'll be called upon to treat patients primarily in industrial accidents who have suffered a hot tar or hot plastic contact. This almost always involves the hands, from time to time the feet. This is a little bit different than our usual philosophy where we say the burn wound has the lowest priority. The plastic material or the tar may continue to be hot up to and beyond the time that you encounter the patient. This is one of the exceptions where the rescuer has the opportunity to alter the course of the injury because of immediate treatment. What you want to do in those cases is to cool the tar or the plastic so that you drop the temperature below the threshold where it damages tissue. The exposure of the patient to cold is minimal because the plastic material acts as an insulation, and you're really not making the patient cold, you're making the resin cold. There is no need at the scene to worry about chipping this off or removing it. The primary response when you get to the scene is to cool that. Cold water will do this best. If you can't find water that is below room temperature water is perfectly acceptable because that's clearly below the threshold for damage and it's going to be cooler than the substance itself. There is no rush at the scene to attempt to remove that. That can be done at the hospital later on. The damage is done by the temperature in the tar and resin kinds of accidents. Lower the temperature and that stops the burning process. Worry about removing the material later.
Inhalation injuries and thermal burns are the most common ones that most of us will encounter. Next, we'll address electrical and chemical burns. And finally, pain management and wet versus dry treatments. While the extent of thermal burns is obvious, being worst on the surface, the damage caused by electrical and chemical burns can be subtle. Skin damage from electricity is generally limited to the points of entry and exit of the current. The higher the voltage and the longer it's in contact, the worse the burn. The greatest amount of damage is often deep within the tissue. Electrical current passing through the body can disrupt the heartbeat. Severe muscle contractions or falls may cause fractures. This patient lost his foot as the current entered his body through his arm and left through his lower extremity.
Certain types of burn injuries deserve special consideration, particularly high voltage electrical injury and chemical burns. It's important for you, the rescuer, to realize that with high voltage electrical injury, these patients may have significant cardiac abnormalities and in fact may have multiple system trauma due to either a fall from a light standard or top of a building, or because of the passage of electric current through either the chest or abdomen. So these patients truly need to be evaluated in exactly the same manner you would evaluate any other victim of multiple system trauma. You need to also bear in mind that because of the propensity for cardiac damage, these patients need to undergo cardiac monitoring both at the scene and throughout their transport. Also bear in mind that with high voltage electrical injury and destruction of underlying muscle, these patients may develop myoglobinuria. Their urine may turn an amber or red color. The precipitation of myoglobin in the kidneys can lead to renal failure. So in victims of high voltage electrical injury, it's extremely important that you administer fluid in a large enough volume to clear the urine.
Before you assess the electrical burn patient, assess the scene. If the source of the electricity is still present, approach very carefully. Extreme high voltage can travel through the ground to the extent that you will feel it through your shoes. Obviously, don't go closer if this happens. Call for advice from the power company or other source if you have any doubts regarding the safety of the scene. So again, complete your scene assessment before your patient assessment.
Electrical injury to the patient may cause instantaneous or virtually instantaneous death because of cardiac fibrillation. The current applied across the body may occur in the proper sequence with the electrical activity in the heart to cause ventricular fibrillation. If you have the equipment available to make that diagnosis with certainty, then of course you must use it and act upon it at once. If you don't have the proper equipment, finding a pulseless and unresponsive patient following an electrical injury, make the presumptive diagnosis of ventricular fibrillation and initiate CPR. Patients who do not fibrillate at the time traditionally have been monitored closely for several days against the possibility of cardiac arrhythmias. As we and others have analyzed our data, we find that the risk of cardiac arrhythmias developing in the post-electrocution phase have perhaps been exaggerated in the literature. Nonetheless, we routinely monitor our patients because we have found young men following industrial electrical accidents who have had acute myocardial infarctions a day or two post-injury. So cardiac monitoring is important, and being aware of the possibility for myocardial infarction is an important one in following these patients. With an electrical injury, the electrical current passes through the interior of the body. The electrical current preferentially flows along the muscle bundles. It heats them internally, and it can destroy them immediately, or the heat can injure the blood vessels so that in hours or days following the accident, the muscle becomes necrotic. So you could have a severe tissue injury in an electrically injured patient with a small area on an arm or a leg where they came in contact with the high voltage source. You can have tremendous damage under what appears to be normal skin. Electrical injuries should all be looked upon as very serious. So the electrically injured patient, in summary, be sure you're not the next victim if you are not experienced or trained in effecting rescues from high-tension towers or from downed electrical lines. Do a complete trauma assessment. Dislocations, fractures, and other traumatic injuries are quite common with electrically injured patients. You cannot assess the damage internally by looking at the patient's skin. Finding a pulseless and unresponsive patient following an electrical injury, make the presumptive diagnosis of ventricular fibrillation, and initiate CPR. As soon as your trauma assessment is complete, these patients should be transported to the hospital and transferred to a burn center.
The final burn category of this lesson is the chemical burn. These will continue to burn until the chemical is used up or removed. Quick action to neutralize and remove the caustic agent can reduce the severity of the injury.
With respect to chemical burns, I think the primary consideration for you as the rescuer is to understand the need for copious irrigation. And ideally, irrigation should again be done with room temperature water rather than with cold water. You need to be certain that because the chemical injury is an ongoing event, that you adequately irrigate the wound to stop the continuation of the process that's leading to the burn.
Irrigation of the burn site will help stop the burn process. In your assessment of the chemical burn patient, remember that chemicals can splash and burn more than one location. As with any kind of burn, communicate the size and depth of the burn as you transport.